Good morning. My name is Hank Head. I'm Director of Clinical Decision Support at McKesson Specialty Health and U.S. Oncology. U.S. Oncology is a network of community clinics across the United States, probably the largest network of community clinics that you've never heard of. They're all branded locally according to each practice, but we have over 350 clinics across the United States. And McKesson Specialty Health is the technology provider for U.S. Oncology. So I'll give a little background, talk about our team. We're going to show you some of the FHIR-based tools that we have developed and have in production, and some of those that we have in development. And then we'll talk a little bit about some of the challenges that we still have, and it's great to be here in the community and see other people overcoming a lot of the same challenges. So when we get to come together and collaborate, I'm like, oh wow, we could use like even that product we just saw. That might solve one of the problems that our team is currently experiencing. So hi Ed, and thank you to the HL7 team for hosting these application roundtables and really the connectathons. Our teams have derived tremendous value from these. A little background, our team is, I would call it a Duke success story. So we were originally a company here in Durham called Preventice, and that was spun out of Duke University Medical Center by Dr. Ralph Schneiderman and Jason Langier. I joined this team in early 2008 to help them with some predictive tools around neutropenia and venous thromboembolisms and pulmonary embolisms. So that company eventually evolved into Preventice that had investors, VC investors, one of which was McKesson. And so that company took those predictive tools through development process. They actually ended up being classified as Class 2 medical devices by the FDA. And essentially, like another product I've worked on before, the burden of the regulatory overhead actually prevented those products completely to coming to market. But while that was happening, we started working on a guideline decision support system, which today has become ClearValue Plus. And that guideline decision support system was supposed to be a tool that would help doctors use the NCCN guidelines in their oncology practices, help them make decisions about what chemotherapies should I use, when and what diagnostic tests should I order, and likewise treatment modalities. When should we use radiation versus surgery versus chemotherapy? So we borrowed heavily from work that Aziz Bakswala had done on Glyph. We leveraged Jello and built our own Ruby-based expression language called EEL, Easy Expression Language, and built this on top of a kind of very custom hybrid graph rules engine that we still leverage extensively today. So back to this team was eventually pulled into McKesson Specialty Health to leverage this ClearValue Plus at the beginning of what has now become value-based care. So we had a pilot project with Aetna back in 2009 at US Oncology, where we were it was called the Innovent Project, and we were piloting value-based care. And Dr. Marcus Neubauer has published 3 papers on that. We've been very successful and have leveraged that to negotiate value-based contracts with payers. But if you're going to participate in value-based care, you have to have transparency about what evidence base you're using to make decisions. And that's where ClearValue Plus comes in. So our team is primarily based here in downtown Durham, although we've rapidly expanded over the last 3.5, 4 years. We now have developers up in Boston, San Francisco, and Austin, Texas. ClearValue Plus as a platform is the rules engine, but it's more than that. It's also the clinical content authoring system that enables us to author and maintain large quantities of huge decision graph data on guidelines. So We have a team of content analysts that maintain complete NCCN guidelines for 22 cancer types. And then soon we'll be adding, in the next 6 months, 6 more new cancers. Our value-based program apps, which I'll get right into the demos pretty quickly here, are designed to leverage that rules engine and that platform to now cover other aspects of value-based care. If you look at the pie of the cost of care for chemotherapy and cancer in general, the chemotherapy is roughly 40-some% of the cost of care in cancer. And Clear Value Plus has essentially tackled that. We've essentially controlled costs for the chemotherapy portion of care as much as we think is really possible, without infringing on the doctor's ability to make clinical decisions. The other next most important aspect in value-based care is keeping the patient out of the hospital. So we're starting to actually pull back off the shelf tools that we developed early on in predicting anemia, neutropenia, venous thromboembolisms, PEs, and we're now essentially rebuilding those tools on the platform to help the doctors intervene early for these symptoms and keep the patients out of the hospital. On top of that, the value-based programs have a lot of rules that drive whether the patients are eligible, and these rules for eligibility start to look a lot like clinical trials inclusion-exclusion criteria. And so we apply the rules engine even for these complex eligibility criteria that the payers need to know when a patient should be covered or do they need to drop out of the value program. So let's talk about what we have first. It's really exciting. We're working on a lot. We're revenue producing. We have revenue producing FHIR apps today that are helping our doctors in our oncology clinics. One that we worked on over the past 4 months here has been a completely smart on FHIR IOM care plan for oncologists. So this reaches into the EHR's FHIR servers. Both McKesson Specialty has 2 EHRs. They both use the Happy FHIR server. So we reach into both, grab the clinical data, represent it to the clinician in this smart treatment plan. They, like our Clear Value Plus product, if there's missing information that's not available as structured data, they can enter it, they can modify it, and then this gets posted to the EHR as their treatment plan, printed, handed to the patient, and now we're working on making that exact same FHIR service available to our PHR team. So the patients with almost no work, that team is now going to hook up this service, and the patient will have access to the same treatment plan that otherwise would have been on paper, would have been quickly outdated. So this is a great success story. And for us, working with our EHR teams through FHIR, these integrations for these little apps are going like twice as fast. It's quite incredible. There's still a lot of work to be done for all of us to get to the point where I can go to a set of like add-on extensions for the EHR and plug a button and have, self-serve application deployment. But we're like well on our way, and that's really exciting, and that's why we really love working with FHIR. So that's our IOM care plan. I'll show you towards the end of the presentation the number of different FHIR resources that are required even for this is extensive. We're working with that NCCN group. We had to work on chemotherapy care plans, very challenging. Some of the repeat concepts didn't exist in some of the early FHIR resources, but we just joined the community and people started working on it. It was amazing. This is our eligibility and enrollment app. So as patients' clinical criteria change, the rules about whether they're still eligible and can be enrolled change, and the billing rules get very, very complex. So it's perfect for our rules engine. Our content authors can author these in our expression language, just like they do all of our clinical rules. And now we have an eligibility and enrollment tool that took a 15-minute process, and our clinics had to add We centralized some of the work. We had to add 30 people just to handle billing for the OCM program for value-based care. We're taking these tasks that were 15 minutes, and now they're 15 to 30 seconds, because we pull all the EHR data that they need to make the decision into one interface, kind of enable them from hunting and pecking, keep them from hunting and pecking throughout the EHR and the practice management system, and then make their decision. Unenroll, stop billing, this patient went into hospice. As I mentioned, we're pulling back into our suite of tools, these predictive and focused symptom management tools. The first two are anemia ones, almost done. We have neutropenia and VTE right after that. But then we're also trying to give the care team in these oncology clinics, they're really trying to move towards team-based care. And they're hiring navigators who can kind of watch and direct work across the care team. So these navigators are looking for early signs for the team to intervene and try to take action. And some of these symptoms that lead to unnecessary hospitalizations are the biggest areas that we're focusing on. But they need to know, do I need to do something or not? So you kind of you can't be too interruptive. You have to kind of tell them with highlighting in the user interface. And we spend a great deal of time doing very deep user-centered design in clinics, tons of shadowing. Like usually for each of these modules, 3 rounds of prototype, usability testing, reprototype, retest, and then by then, we start our agile development process that kind of kicks off, but it's really driven by this user-centered design process. So this interface has had 4 rounds of user testing. The care teams love it because it tells me which symptoms are being managed, those with the gray risk levels, and that's according to the CTCAE grading scales, and then which ones are needing attention. So in this case, anemia, and then those tools that are plugging into our patient-centered health records are now getting data from the patient on pain, anxiety, weight loss, that feeds it back into the tools. I'll just show a few others because I have 2 minutes left and there's so much to cover here. So that's a checklist for the requirements for the OCM program. And then our kind of hit CDS tool is Clear Value Plus. This is the Guideline Decision Support tool. This is integrated into Epic, Varian, ARIA, our 2 different iKnowMed systems. We're working on our 5th EHR integration. It's this 5th one that's purely smart on FHIR. This chemotherapy decision tool has been in production for 4 years. We've been a RESTful, Ruby on Rails shop for the last 6 years, but we switched to these pure API-driven tools 4 years ago. So this is integrated as a tool that's a RESTful API, and with this 5th integration, it's all being converted to the Smart on FHIR. So that's incredibly exciting for us. These workflows get extended into prior authorizations, and I don't just mean like this, imaging study is approved for this, ICD code. These are complex sets of clinical criteria that the payers are now demanding in order for us to be able to prove evidence-based medicine. And then if you can prove that, you can negotiate better value-based contracts. And to prove it, we report on it. So some of our reporting is even payer-facing, so they can see in real time how the practices are doing in their value-based contracts. This is our FHIR roadmap. Some of these areas, like the chemotherapy templates, are pretty challenging. Transfusion information from hospitals, really challenging. And then a few people, workflows that involve huge lists of patients that I have to process against eligibility rules, where the care team worker needs to move back and forth between a list and a decision tool, back to a list. These are really hard problems for us that we're working on and look forward to working on with the rest of the community. So I think that covers our challenges as well. Here's a quick list of some of the tooling we're using from the FHIR community. And we're hiring. Our team is growing very rapidly, so we need developers and all types of other positions. That's it.